Welcome to Derms on Drugs, a video podcast brought to you by Scholars in Medicine, the best educational platform in dermatology, and provided at no cost to medical providers. Derms on Drugs is where cutting-edge derm meets hit or miss comedy. I'm Matt Zires, and each week I'm joined by my residency buddies, Dr. Laura Ferris and Dr. Tim Patton, to use our 60 years of combined derm experience to discuss, debate, and dissect the hottest topics in dermatology. It's everything you need to know to be on the cutting edge of derm, and you'll actually have fun listening. New episodes drop every Friday on Scholars in Medicine, Apple Podcasts, Spotify, and any other major platform you might use. Just a reminder for everybody, there is a video component that has the key figures and tables from the articles we talk about, and the episode description has a link that'll take you to Scholars in Medicine where you can get the links to all the articles and other resources we discuss on the episode. So this week we've got something super special for you. So there has been such cool stuff in the area of what I would call non-invasive hair restoration. So supplements and helmets and all kinds of stuff that we're actually going to break this deep dive into 2 episodes. So this week, we're going to talk about 3 articles that Drs. Patton Ferris and I thought were great. One looking at folliculitis decalvans, one looking at lab testing in people with telogen effluvium, and one looking at all of the hair supplements that are out there. And then next week, we're going to have a special guest, Dr. Michelle Tarbox, and we are going to really go in depth into all of this stuff. So let's go ahead and get into it. Dr. Ferris, what do you got?
So I picked a paper that was published in EADV, which is Management of Folliculitis Decalvans, the EADV Task Force on Hair Disease Position Statement, Waskiel Bernat et al. So, why did I pick this? Folliculitis decalvans, they can be challenging. I gotta be honest, I also recently moved to North Carolina. I have a far more diverse patient population than I had in Pittsburgh. And so I was like, there is, telogen effluvium. I've seen that. I see it all the time. I'm like, let me brush up a little bit on folliculitis decalvans, see what other people say. So I wanted to see, is there anything that I didn't really know? But, this is also the European perspective on it. So one of the things that I thought was kind of interesting was that, they talked about folliculitis decalvans existing in a spectrum with lichen planopilaris, and they had some long abbreviation that there are these patients who sort of have both. They have some LPP and some FD. I never really thought about those 2 diseases going together. You guys think about those 2 as being oh yeah, some people have overlap.
Yeah. No, they used to talk about there being lymphocytic scarring alopecias and neutrophilic scarring alopecias, and this were the prototype 2 diseases of the 2 different totally categories.
I think that my theory is that folliculitis decalvans, when it doesn't have the neutrophilic pustular component to it, that you may not see the neutrophils there. And I think it's misdiagnosed as LPP. I think I had patients that I saw all the time where they would come in and clinically diffuse erythema, yes, perifollicular scale, but it wasn't that sort of very selective attack on the hair follicles that you saw in LPP. And the patients came to me with a diagnosis of LPP. And I was like, this is not LPP. I think a lot of people depended on those newts to be there. And I don't know that they're always there in folliculitis decalvans.
Do you think
that's my theory?
Will a biopsy separate the 2 in that situation, or do you think even the biopsy is
so the
iffy?
Biopsy with LPP? When you have this is totally my experience based on nothing. When you have a patient where you're slam dunk LPP, right? Your FFA patients, you biopsy that, and the pathologist is this is lichen planopilaris. When you biopsy folliculitis decalvans and they don't have that pustular process, it's one of those weird reads and path where they're I don't know, there's a little bit of inflammation and it's kind of scarring, and I don't really see neutrophils, so I don't know. But in my experience, slam dunk LPP from a clinical standpoint, the pathologist will flat out say lichen planopilaris.
Okay.
Okay.
All right. Fair. All right, Ferris, let's go.
All right. There's an FD, PGA. There's a PGA for everything. So there's an FD PGA, 0 clear, 1 mild, which is perifollicular erythema and hyperkeratosis, no pustules or crusts. Maybe that's what you're talking about.
It is
stage 1. and then mild, and then they skip right to moderate in this figure, which is a little bit weird. Enter 3, but they call it 3. Interfollicular erythema and or hyperkeratosis beyond the hair follicles, possible presence of several pustules and or thin crust. And then 3 is interfollicular erythema and or hyperkeratosis beyond hair follicles, many pustules and or thin crust.
Okay.
All right. So they talk about topical therapy. Not much that was new here. Ultra potent topical steroid daily for 1 to 5 weeks. Can also consider adding topical antibiotics. They talk about using topical tacrolimus BID, topical dapsone gel 5% 3 times per week to decrease flares. I was kind of like, if you're going to use it, wouldn't you just use it every day? Topical washes with Hibiclens, intralesional therapy, TAC 2.5 to 20, intralesional Q1 to 3 months, decrease concentration frequency as erythema decreases. There's some small studies with PDT as well. I've never done PDT for this. What do you guys think about those?
Don't think they
Topical
do much.
steroids.
Yeah,
Topical steroids.
maybe some clobetasol, some ILK.
Yeah, ILK I tend to do. Oral antibiotics, tetracycline, not totally shocking. I think that's kind of one of our standbys. And then clindamycin, clindaryfampin, 300 BID of each for 10 weeks. They said is, one of the most effective treatments. In one study, 55% of patients had good response, no recurrence in 2 to 22 months of follow-up.
Hmm.
And then they also said there's some small studies to support azithromycin or clarithromycin. Clindaryfampin, I think, is something that is like a reasonable go-to if people have pretty active disease. Thoughts?
Yep.
Agree completely. I think
100%.
clindaryfampin. Yeah. What
Yeah.
patent?
Yeah, 100%.
Yep. HS as well. I think it's uniquely effective in HS as well. I think the penetration of the rifampin is into the follicles is important.
Right. No, agree. And then oral steroids. They said like prednisone or prednisolone 0.5 to 1 mg per kg per day, or dexamethasone 0.5 to 0.75 mg per kg per day twice a week are recommended for highly active folliculitis decalvans, usually in combination with oral antibiotics. The duration should be limited to approximately 3 weeks. I got to be honest, I don't do a lot of oral steroids for this. Do you guys?
No.
If somebody, no, but if somebody, Jerry Shapiro likes to use the term a trichologic emergency, where if you don't shut down the inflammation immediately, you're literally losing follicles by the day. So
Okay.
that's the terminology he likes to use, a
It's
trichologic
like
emergency.
CPR for the hair follicles. I could see them.
Exactly.
We're clear.
Chunk.
And then the other thing they talked about was isotretinoin, which I think makes sense. They had like 0.1 to 1 mg per kg for 1 to 8 months. And so they said complete response observed in 82% of cases in one study. They're very big on isotretinoin in this paper. So they actually have a one figure in here where they're like, do you have mild, moderate, or severe disease? All of them go on isotretinoin. The only difference is moderate should get some oral antibiotics to calm them down, then go to isotret, whereas severe should get, apparently in the trichologic emergency phase, oral antibiotics and glucocorticoids, then go on to isotretinoin. Then they're like, then you go into all your other, potential things, meaning hydroxychloroquine, oral dapsone, your TNF inhibitors, preferably adalimumab, your JAK inhibitors, PDT, surgical excision, blah, blah, blah. But basically, like their take home was everybody who has this should go on isotretinoin. It's just a matter of like, do they need something first, like an antibiotic and or a steroid?
Is that how you guys have always, like, I didn't think of isotretinoin as like that's the be all end all of everybody with folliculitis to yeah.
Me
No.
neither.
10 weeks clindaryfampin, and I mean that works really well. Maybe they're just seeing more severe disease. I don't know
Maybe
if
it's
I've ever.
all LPP. Maybe that's what it is. No,
That's it.
no, I thought I thought it was interesting too, because I'm
Huh.
like, it's sort of like on my, my therapeutic ladder, but I'm not like, okay, it's just a matter of when we start your isotretinoin.
Yeah,
I
right.
have not looked at this disease in that way. So I thought that was interesting.
Yeah.
Adjuvants are the topical intralesional glucocorticoids as first line. Second line is tacrolimus, topical tacrolimus, or dapsone. So interesting, sort of a little difference, but maybe it'll make me think about going a little bit earlier. Think about isotretinoin more often. That was my take on it.
Reasonable. Yeah, when I looked through the text of the article, they seemed the implication was the isotretinoin is kind of like acne, where you give them the isotretinoin for a full course and then puts them into long-term remission. Which, if that works, yeah, I can get it if I get it if it puts them into remission. Sure. Yeah. All right, Pat, what do you got?
All right, my deep dive is from the Journal of Cosmetic Dermatology, is titled Retrospective Review of 2,851 Female Patients with Telogen Effluvium, a Single Center Experience by Karakoyan et al., available online, February 2025. This was a retrospective study from Dicle University, I think that's how you pronounce it, in Turkey, involving 2,851 female patients that presented with hair loss between 2010 and 2024 and had lab work done. Ages of the patients ranged from 8 to 79. Most of the patients, 83.5%, were between the ages of 18 and 45. Table 1 looks at the population overall. Table 2 breaks down the groups into less than 18, 1845, greater than 45. But most of the patients were in that 1845 group, so I think Table 1 is sufficient. So just going down the table, 11.1% of females with TE had low hemoglobin, 46.5 had low ferritin, 29.5 had low iron, 5.8 had low B12, and 0.6 had low folic acid. 2.4 had high TSH. That would kind of represent hypothyroidism, at least most cases of it. And 1.3 had low T3. But without a comparison group of women without TE, I don't know what all of that data and paper means. Ferritin numbers, I texted you guys over the weekend. It was kind of driving me crazy. Like the 300, like
Get a life,
nanograms per
Patton. Get a
deciliter.
life.
What's that?
Get a life, Patton.
So yeah, units that I just was like, this is not what we use. It was like when Homer Simpson was buying a car and the salesman was like, she'll go 300 hectares on a single tank of kerosene. Like, I didn't know what that meant. So we usually talk about ferritin in terms of micrograms per liter. And so that's the concept I have of what's deficient, what's not. But when I tried to convert their values, like the value of 18 nanograms per deciliter would be converted to 0.18 micrograms per liter, like which would be your ferritin level if you died from blood loss, after which you start to lose significant amounts of hair. So does this information help us at all? I don't know that it does. I really didn't get the point of table 2. Like they broke down the ages, but percentages were similar enough. So I don't know that really.
But that 18 to 45 is like menstruating women. They are probably the most anemic group, right? Maybe that was part of it.
Yeah, so like statistically speaking, they had the lower ferritin, but it was like 47% of the 1840 to 45 versus 40% versus like 43. I mean, it's like in the same neighborhood. So It wasn't like anything jumped out at me. Yeah, I don't think performing blood tests on patients with hair loss like TEAGA, absent any symptoms, or honestly even with symptoms, I don't think that makes any sense. This paper really didn't change my belief in that. The iron deficiency thing in hair loss kind of drives me crazy. I remember reading a paper, it was from 2006, like Ferris was still in high school. And I remember reading a paper in the JAD, like Wilma Bergfeld is one of the authors, and it was like this 20-page paper. And in the abstract, it said, currently, there is insufficient evidence to recommend universal screening for iron deficiency in patients with hair loss. And then one sentence later, it was like, we check iron studies on everybody. And like 20 years later, we're in the same exact place, insufficient evidence. and it's recommended that we do it in all patients. And I thought this paper would kind of tease out, does that make sense? Does it not make sense? And it really didn't answer that question. So I
No,
don't
it's
know.
I always like so Jerry Shapiro wrote an article like 3, 4, 5 years ago.
Yeah.
Uh,
Journal of Drugs and Derm.
yeah, JDD,
Yeah.
where
2021.
yeah, so just like did the people that they tested people and then they supplemented them if they were deficient, and his takeaway was it didn't do any good. Like
Yeah.
people might have hair loss and they might have a vitamin deficiency,
Yeah.
but like an iron deficiency in particular or low vitamin D, but the two aren't related. It's just a random, like nobody's ever done, I've never
Yeah.
seen a good study because it'd be easy of just women who have telogen effluvium versus a matched control. Like I haven't seen anybody do that,
Yeah,
which
it's
it
amazing, right? Because how common is TE iron study? That's an easy thing to do. And even if you wanted to do the study where you supplement versus non-supplement and placebo, I mean the placebo part, that would cost a lot of money and be hard.
yeah.
But it's a low cost intervention. It's like I feel bad for our hair loss patients at how poorly dermatologists, like the doctors who really should be studying this and finding good scientific evidence, and we're just not. We're just not.
So now the other question to me
Oh,
here,
Lisico was was like the co-senior author on that Shapiro paper. Lisico was a former Pitt resident.
That's right. We're very proud.
change. No wonder they're changing the world. They got trained by you too.
Yeah.
That's right.
Okay.
Kristen Losico, hair
Okay.
expert in New York.
Yep.
Yes.
So what's the downside? Because that's part of me is always like, well, I think it helps. No, but if a patient asked, would you? I would gladly order the stuff, but I'd be like, I don't think it's going to help at all. But like, I don't think it's going to hurt.
Healthcare costs, right? You find stuff, it's like, oh, it's the, oh, my iron. Oh, what about this? Why is my MCV low? Why is my RD, whatever? Like, it just like opens up Pandora's box, like to be doing a lot of testing for things that is not going to guide therapy.
I
Ferris, if your
don't
hair started falling out tomorrow, you would be begging for drug tests or blood tests out the wazoo.
No, I wouldn't.
I don't know what you're basing that on. But what I will say is no, I don't reflexively order anything. And then when the patients say my hair's still shedding, shouldn't we be checking my thyroid, my iron, my zinc, my vitamin D? Right on this, I'm like, of course, that's a great
Sure.
idea. I did it with a patient, and then 2 weeks later, he said, my insurance said they're not covering any of this blood work. They said it's not indicated. And I
Wow.
was like, I don't know what to tell you. Like, that's why I didn't order it from the get-go.
Yeah,
Yeah,
no,
that's it.
it does open up all of that stuff. Like it does like contribute to costs, and it's like the patient costs, and you have to have a good reason to do it. And then I'm like, if they really think it's vitamin deficiency, I'm like, take like a Flintstones chewable vitamin every day. That pretty much covers all of those things.
Well, do you
And they
guys
taste good.
what about an
What's that?
androgenic in women with pattern alopecia or androgenic? There are some people who order right DHEAS and testosterone and sex hormone binding globulin and everything. But I've never seen any evidence that like if you got hirsutism, sure. If you've got
Yeah, if
like
you have other
you know
Yeah,
masculinization, that's not a word. You know the word.
masculinizing
Thank
feature.
you.
Yes.
Then sure, but not just for AGA.
No, I agree. I don't do it for that either.
I do ask women about if their menstrual cycle is regular. And if it's not, I will tell them to like mention to their OBGYN, hey, my dermatologist said my hair could be an indicator of PCOS. I have no idea if there's any actual rationale behind that, but I figure I'll leave it up to the OBGYN to decide if they want to test and diagnose for PCOS, because I feel like that's got some stuff they can do for it.
Yeah, if
But
I think they have PCOS, like, what do you get? Total and free testosterone, right? Like, you can do, and I have to look up when like the once every 3 years that I see a woman that I'm like, she looks like, man, that like this is more than just like it's really bad hirsutism or something that I'm like the facial shape is changed, and then I will order, but I have to go look up the labs. I don't have it memorized anymore.
yeah.
The PCOS part, like, yes, you can look at that, but it's more like bad acne plus hirsutism plus AGA.
All right, we're going to move on to my article, which was published in 2023, but I think it was such a good one that it's about such an important topic that comes up all the time. So, evaluation of the safety and effectiveness of nutritional supplements for treating hair loss, a systematic review. So the primary, so this is basically a review article looking at the evidence for all of these different things. And right, the first thing that I would say is we've got plenty of randomized double-blind placebo-controlled trials showing that supplements help. Right, if you've got thinning hair, whether you're a male or a female, supplements help. And the real question then becomes, whenever you're looking at these supplements, is there one in particular we ought to be recommending? And it's really an interesting, because there's no head-to-head trials, right, of any of these against each other. So I tend to end up thinking about it in terms of cost to a significant factor, that in the absence of evidence saying use one instead of the others, I'm gonna pick kind of what's cheapest. So the ones that they had in here, I spent some time today looking up pricing for all of these and where you could get them. And I did pick up a couple of things that I'm going to start doing a little bit differently. So we've got some evidence that pumpkin seed oil works fairly well as a 5-alpha reductase inhibitor, and we've got some evidence to support pumpkin seed oil. And it's cheap. You can get a decent pumpkin. There's a bunch of pumpkin seed oils on Amazon for $15 a month. Those are reasonable to do. Next one that has some data behind it was capsaicin. And so capsaicin plus isoflavones are reasonable data, but I couldn't find any products that specifically had those that were still available and on the market. There was like one being sold in Canada, but I wasn't sure if you could like get it from America, and I didn't know about the Canadian dollar conversion, like whatever. So I left that one out. Keratin, I think we've got good data for two different keratins. One's called Pantogar, Pantogar. Evidence is mostly in German, so I couldn't look at it very much, but you can get it for $45 a month. The one that I tend to prefer is called Cynatine, Cynatine, HNS. That's $18 a month for the Now. So one of the brands of supplements that I recommend kind of for atopic derm stuff and other things is this Now brand. So you can get the Cynatine for $18 a month. It's got evidence that it makes your hair shinier and it makes your hair stronger. So it doesn't grow any new hair, but makes the hair that you have look better. Then you've got the marine. So you can get it for about $18 a month. Then you got the marine complex products. So you got two of those, Viviscal and Nourkin, Nourkin. Those are both about $33 a month. So they're priced identically. Right. It's hard to, now that I know about Nourkin, like I didn't know about it until today. I don't think one has like massively stronger evidence than the other. So either one of those, $33 a month. Then you got Nutrafol. And Nutrafol's got pretty good evidence, but it's also by far the most expensive, right? So Nutrafol's $88 a month. So it's not cheap. It's got a whole bunch of stuff in it. I absolutely think it works. There are some cases of liver toxicity reported with it, but we're looking at $90 a month so we're looking at basically 3 times the cost of the marine complex ones. Then another one I didn't know about that goes along with the pumpkin seed oil that I hadn't heard of. So pyocanidin, I don't know what the hell you say it, but it's from a special apple that the data shows it increases how long your hairs spend in anagen. The one that I would get is called Applewise, like literally the word apple, Wise, Applewise on Amazon. It's $16 a month. And then the other one that I hadn't heard of before, so Lambdapil, which is cysteine, saw palmetto, which is a 5-alpha reductase inhibitor, and then silicone to increase hair strength. And that one again was $60 a month. I actually asked AI to like put together like taking like if cost wasn't an issue and you could take as much as you wanted, like what wouldn't overlap completely. And the takeaway I got was, well, if it was a guy, you could do pumpkin seed oil. You could do kind of all of them: pumpkin seed oil, keratin, Viviscal, Nutrafol, piosanidin. Now, the Lambda pill probably overlaps a lot with the other ones. But so if you wanted to, you could do like all 4 of those. But if I personally was going to do one, or if like a person in my life was asking, I would go with Viviscal because it's the cheapest, that has pretty good evidence. But if they wanted more, then I don't know if I would add on the piocanidin or the pumpkin seed, or if I would then, add in the keratin or whatever. But the nice thing with the keratins, though, that's also your best go-to when somebody complains about nails, because we have good data that synetine makes your nails stronger and more resistant to breakage. And so that's the other keratin is good for both your hair and your nails.
Now, I like the idea of the keratin because, I hate the question, like, what can I do for my brittle nails? And now I can be like, I'm like, do Dermanail. Now I'm going to be like, take Synodin, or I'll look it up.
Synetine.
Citadine.
Yes.
Good. I've got something to answer. How about ketoconazole shampoo? Does anybody do that? Because of that wasn't, I remember looking at that paper a couple of years ago. So this idea that, ketoconazole shampoo is also a 5-alpha reductase inhibitor. And so it blocks DHT in the scalp, but you leave it on, you put it on the scalp, you leave it on for 10 minutes and then rinse it off.
I want to thank all of our listeners for joining us. If you got questions, comments, ideas for topics, shoot us an email at questions@dermsondrugs.com. And we hope you learned a few things. We hope you laughed once or twice. And mostly, we're hoping you're planning to join us next week. Until then, I'm Matt Cyrus.
I'm Tim Patton.
And I'm Laura Ferris, and we are Derms on Drugs.